a real pleasure to speak at this wonderful event. I really enjoyed this in the past in person, and I hope everybody is doing well with under the circumstances with the pandemic. So I'm going to be speaking about management of ACLF, kind of from the ICU perspective. And as Charles mentioned, we recently put out the part one of the guidelines of the management of ALF and ACLF from the Society of Critical Care Medicine. And I just kind of refer you to this reference. Just so you are aware, we are in the process of putting out the part two of the guideline. As you can understand, there are many different intensive care docs and hepatologists that have been involved with this, so there's been a bit of a delay because of the pandemic. So, as you're all aware, for the purposes of this talk, when we talk about cirrhotics in the intensive care unit, I use the term acute on chronic liver failure, which was validated by the Cliff Group and Richard Moreau back in 2013 with the canonic study. And essentially, we think of this as a decompensated cirrhotic with organ dysfunction. And they essentially kind of validated this in a group of 1,343 patients that were admitted to hospital, of which just over 400 had evidence of organ failure. And they defined ACLF based on different grades. And essentially, the grade of ACLF correlated with the number of organ failures. And as you can see in the chart on the right, that having 3 or more organ failures, or ACLF3, was associated with almost an 80% mortality at 28 and 90 days in the absence of transplant. So the first question is why do cirrhotic patients end up with multi-organ failure in the intensive care unit? And it's mainly for these things. It's for circulatory management, respiratory failure, acute lung injury, and more so now with the COVID pandemic, hematological support and renal support in the setting of acute kidney injury. So just as a reminder, we know that traditionally with cirrhosis that there are circulatory abnormalities that occur as a result of portal hypertension and portal systemic shunting. This leads to a decreased clearance of vasodilatory compounds such as nitric oxide and cyclic GMP, which results in spontaneous systemic vasodilatation, leading to increased systemic vascular resistance. And to compensate for this, you get an increase in cardiac output. And as you can imagine, this kind of has two consequences. That at some point, the cardiovascular system is no longer able to compensate, and you end up with a situation of relative arterial hypovolemia. As a result, in the kidneys, this can lead to, to compensate for this, getting activation of the renin-angiotensin system and the sympathetic nervous system, you can end up with hyponatremia and eventually with what we call beta-renal syndrome. Also with this, as we know, the cirrhotic physiology significantly decreases after load and can really mask significant cardiac dysfunction. And there is the well-known phenomenon of cirrhotic cardiomyopathy. So some of the things that have changed recently is how we assess cardiac output in cirrhotic patients or ACLF patients. And we really moved towards the dynamic methods such as bedside echocardiography. One of the things that did come out in the recent SCCM guideline was suggesting the use of dynamic rather than static methods to assess cardiac output in ACLF. And this can be done with simple bedside echocardiography, where with this, you can get assessment of both left ventricular and right ventricular function, and also fluid responsiveness. There are other more traditional methods, such as CVP monitoring, which I highlight. Some centers are using thermodilution techniques, although they are not standard of care, and they're not used widely. In terms of the choice of vasopressor support, this was one thing that we did address in the guideline, and still norepinephrine, just similar to the general critical care population, is the first choice of vasoconstricting agent in ACLF, partly because it's widely available and also it's based on cost. Traditionally, we've advocated for a mean arterial pressure greater than 65 in a critically ill patient, or including an ACLF patient. The exception to this would be in somebody with acute kidney injury, particularly if you think the cause of AKI is hepatorenal syndrome. At that point, it would be better to target a higher mean arterial pressure of 75. One other thing to mention is that relative adrenal insufficiency is quite common in ACLF and cirrhotic patients, and one would consider a divided dose of hydrocortisone. So, as I mentioned before, one of the biggest or most common precipitants of ACLF is bacteremia and sepsis, and this happens for a variety of reasons. We know that in cirrhosis, you get loss of the tight gap junctions in the gut, leading to bacterial translocation. As well, you have alterations in the portal circulation with portal systemic shunting and collaterals, as well as dysfunction of many different immune cells, such as Kupffer cells in the liver and NK cells and other macrophages. And what this eventually leads to is bacterial translocation, leading to spontaneous bacterial peritonitis, and in some severe cases, bacteremia. Now, both of these settings can have significant consequences in a ACLF patient. This was a study that we did looking at a large bacteremia sepsis database from the US, where we found that if you had a cirrhotic patient with SBP and septic shock, that your overall survival to hospital discharge in the absence of transplant was only 18%. Now, this is an older study that was published in 2015 with older data, but it just really highlights this is a severe or a very difficult population. Furthermore, the learning point out of this study, pardon me, is that after you adjusted for other markers of severity of illness, one of the most important factors in a patient with SBP and septic shock is early appropriate antibiotics, where we found in this population, after adjusting for a variety of different factors, that every hour delay of appropriate antimicrobial therapy was associated with an increased risk of death of almost 1.9 times. And this is also mentioned in the guidelines. So one of the few things that we can do in septic shock and ACLF is early appropriate antibiotics. So when we look at different causes of respiratory failure or acute lung injury in ACLF, there are certain etiologies that are specific to liver disease, such as hepatic hyperthorax, hepatopulmonary syndrome, portopulmonary hypertension, and alpha-1 antitrypsin. And then there are other causes that are non-specific, which also tend to be very common, including pneumonia, pulmonary emboli, etc. There is a standard definition of acute lung injury based on the which we call now the Berlin definition, where it's defined as mild, moderate, and severe, and this is based on a PO2 FiO2 ratio, and it does have significant implications on how we ventilate these patients if they need mechanical ventilation. So generally, this was one thing that we also reviewed in the guideline, where there isn't kind of specific mechanical ventilation recommendations in ACLF populations. However, in general, in the critical care population, what has been evidence-based is a lung protective strategy, and essentially this is to essentially aim for a higher positive expiratory pressure, a high PEEP, with a low plateau pressure. This is to avoid barotrauma or causing complications in the lung. One other thing to mention is that with regards to the treatment of hepatic encephalopathy, the one point that might be different that in a standard cirrhosis population is that one of the challenges we face with lactulose is it can lead to significant bowel distension. And this can cause intra-abdominal compartment syndrome in the ICU setting, meaning it may get difficult to ventilate an ACLF patient, or furthermore, it can exacerbate acute kidney injury. One way to get around this is actually the use of polyethylene glycol, and this was a study on the use of PEG that was published back in 2014, which did show a benefit in treating HE. And one of the ideas here is with PEG, you don't get the bowel distension that you do get with lactulose. So while it probably is still, the data isn't as robust as for other therapies, this is something to consider. With regards to acute kidney injury in cirrhosis and ACLF, the differential is in fact broad. And what we tend to think classically of hepatorenal syndrome, where this is the setting of splanchnic vasodilatation and a renal arterial vasoconstriction, there are other causes of acute kidney injury, and I just highlight them here. And one classic example is that you can get cryoglobulinemia with hepatitis C, which sometimes gets missed. So there are new guidelines with regards to the different staging of acute kidney injury and cirrhosis. And this has been harmonized with a lot of the other AKI definitions in other populations. And as you can see now, we now define stage 1 acute kidney injury as an increase of serum creatinine of 0.3 milligrams per deciliter, or an increase of greater than 1.5 times baseline. And when you see these cutoffs, the rationale for this is we're now stratifying patients with different prognosis, with stage 1, 2, and 3, where you have a patient with a creatinine of greater than 4, and in some cases requiring renal replacement therapy. Now, the etiology of acute kidney injury does have important clinical relevance. So one thing to highlight from this study that was done in Spain back in 2011 is that in this study, you can argue the limitations, it was a retrospective chart review, was that only 13% of patients with acute kidney injury and cirrhosis actually met the definition for hepatorenal syndrome. However, they had the worst prognosis with an 85% mortality at 90 days compared to other etiologies of AKI. So that, there are two take-home points here. Number one is that HRS is actually a lot more rare than we think, and there are other causes of AKI and cirrhosis that potentially are reversible. But furthermore, if you do have HRS, and some of the subtle signs of this would be somebody with hypotension and somebody with more advanced liver disease, is that once you do have this, it is associated with a poor prognosis, which likely reflects the fact that patients had more advanced liver disease. So the implications of acute kidney injury are also important in the setting of transplantation. So while we think of hepatorenal syndrome as something that is potentially reversible with transplant, there's likely a spectrum where after, if a patient has had HRS for several weeks, you can end up with established ATN and glomerular sclerosis after a period of time. And this becomes a challenge when we make decisions about, do we list the patient for a kidney transplant as well as a liver transplant as well? And currently, if you look at what kind of that definition of ATN in the setting of cirrhosis is, often we make, it's not entirely evidence-based, but most, this is based on expert best practice statement, you could say. And generally, this is done at the setting of either 6 weeks of requirement for renal replacement therapy before transplant, or a GFR of less than 25. And as you can see, if you have ATN, and this was shown nicely in a study in 2012, that the rates of chronic renal dysfunction are significantly higher. But furthermore, having ATN after transplant is associated with a much worse outcome post-liver transplant. And this is the reason why we don't generally like having post-transplant patients on chronic dialysis. I know that Terlipress, unfortunately, is available in India, and it is one of the therapies that we use in HRS. We're still waiting for its approval by Health Canada and the FDA. And there was a third study that was done on this recently. But just one thing to highlight, we know that patients that are getting norepinephrine or terlipressin are quite ill and have very advanced disease. So in this population, it is hard to directly show a mortality benefit. However, what Boyer showed nicely in this study was that those patients that had HRS reversal, whether it was from terlipressin or not, they had a significantly improved outcome. As mentioned, that in countries that don't currently have terlipressin widely available, and we are one of them, probably at this point, norepinephrine is non-inferior. And the general practice would be is really we drive up their mean arterial pressure, and we would target a MAP of 75. One of the more controversial areas at this point is, when do we start renal replacement therapy? And having sat on this guideline, we don't have any direct evidence per se of this in ACLF or cirrhotic patients. If you look at the more broader critical care or critically ill population, there was a study that was published recently in the New England Journal, the START AKI study, which looked at early initiation of renal replacement therapy versus standard recommendations. And as you can see, looking at the two Kaplan-Meier curves, there was no statistically significant difference. So particularly in the setting of somebody that is on the transplant list, whether we do this at an earlier stage or based on standard criteria, based on acidosis, volume overload, and hyperkalemia, there hasn't been a benefit that has been borne out. More practical points of view in terms of what modality to use, our standard practice in ICU is the use of continuous veno-venous hemofiltration. And the main reason for this is that this is a simpler circuit, and we know that cirrhotic patients have deranged coagulation. And often we can get away with this without using anticoagulation. We can do it with just saline flushes. If you do use a more complex renal circuit like continuous veno-venous hemodiafiltration, then often you need to use something like heparin. And we know that there is a challenge with using regional anticoagulation with something like citrate because patients with abnormal liver function can sometimes develop citrate toxicity because they're unable to metabolize the citrate complex. So kind of one simple approach, just to make you aware that this flow scheme was published by the International Club of Societies in 2015 that shows if somebody has stage 1 AKI that we look for precipitants, give them a volume challenge, and then we kind of follow them. And if they progress to stage 2, really at that point, you would consider albumin and at least vasoconstricting agents if it's truly HRS for things which, depending on what part of the world, in our center, it would be midodrine and octreotide on the ward. In your part of the world, it might be terlipressin in a step-down setting. And obviously, if that deteriorates, you would get an ICU consult. With regards to variceo bleeding, I'll just make kind of two quick points. So generally, outcomes for variceo bleeding are improving, and the most important predictors of mortality are actually the severity of the liver disease rather than what the endoscopist sees with the gastroscope. We know that there is good data that suggests that terlipressin as a splanchnic vasoconstricting agent controls bleeding and decreases mortality. Unfortunately, as I mentioned before, this is not licensed in North America, so we still generally use octreotide, which in combination with variceo banding has been shown to improve outcome. We know that there's data that shows early tips in the secondary prevention setting is associated with a decreased 1-year mortality. However, this study has been criticized that it was highly selected, and there was only 64 patients that ended up being randomized, but it's just something to consider. And we know that based on the Villanueva study that the transfusion trigger that we tend to use after you get some kind of hemodynamic stability is 7 grams per deciliter. And that's based on this study from Villanueva and colleagues that just showed that using a restrictive strategy in patients with GI bleeding and liver disease, which is the lower parts of the forest plot, certainly was not inferior, and in Child-Pugh AB cirrhotic patients was actually associated with a mortality benefit. Just finally to mention with regards to prognosis that from the CLIF group, and I know that there's also the PASL ACLF definitions as well. I just find that the CLIF definitions of organ failures are simpler to use because they were modified from the original Jean-Louis Vincent SOFA score. It's based on 6 different organ failures. And one thing that Rajiv Jalan and colleagues did is they created a novogram by including, this is a logarithmic scale which includes age and white count, and ends up with a kind of predicting with a score between 0 and 100, which you can get on an app. And previously what we did is we looked at this in critical care in ACLF patients, not only from Europe but from North America. And we found that once you had a CLIF ACLF score of greater than 70, this was associated with a 28-day mortality of 90%. But one thing I do want to mention is that ACLF is dynamic. And in this study that we did, we found approximately 40% of patients improved by at least 1 organ failure. So not all patients that we attempt with ACLF to treat are destined for a poor outcome in the absence of transplant. And this continues to be the big challenge. In the setting of liver transplant, I just want to mention that we don't have a futility score per se, but obviously the more organ failures you have is associated with a worse outcome. And this is a nice study that was based on the UNOS database by Tulevath that showed that with increased number of organ failures, your waitlist mortality goes up quite significantly, meaning that you don't survive long enough to get an organ. And what they found here that once you had 4 or more organ failures, your 30-day waitlist mortality was almost 100%. And I just mention this because if you look at a lot of post-transplant data, and this is just one example of it, the outcomes of liver transplant in ACLF with multiple organ failures actually look pretty good. But really, I just want to caution you that patients that end up in these types of studies are highly selected because as clinicians, and you'll all be aware of this, that we tend to take a lot of patients off the transplant list because we think they are too sick. So while you see here that based on UNOS, patients with 4 organ failures had a 1-year survival of 80% after liver transplant. It was actually a small number of patients, and these were likely younger patients without other medical comorbidities. So just to summarize key points, when talking about ACLF in the ICU, for circulatory management, dynamic measures of volume status in ACLF are valuable in patient assessment. Using a lung protective strategy in the presence of acute lung injury, early appropriate antibiotics impacts outcome in ACLF and sepsis, speed is life. Consider using polyethylene glycol for hepatic encephalopathy, particularly in those patients that have abdominal distension. Vasoconstricting therapies are associated with reversal of HRS, and responders to vasoconstricting therapies are associated with an improved outcomes. And we still have equipoise with regards to when to initiate renal replacement therapy in these patients. So I thank you very much. I'm going to stop there, and I'm happy to answer any questions you might have.
Thank you, Dr. Dean, for that excellent talk. And there are quite few questions on the chat box, and the topic is open for discussion. Dr. Sonal, you want to take it?
Thank you, Professor Karvellas. I must say that a couple of additions. Professor, it is now Professor Karvellas and not Associate Professor. So congratulations are in order. Secondly, obviously, on that excellent guideline that he's been part of. Obviously, we are proud that he's been part of a field on numerous occasions, and in fact, every participation brings a lot of new questions and new ideas and insights for us. So we are very grateful for your time, Dean. So, there are 3 questions right now from the audience, which I'll just read out from Dr. Sandeep Satsangi. The first one is in a patient of ACLF with hypotension and associated AKI and presentation. Would you prefer terlipressin or noradrenaline? That's number 1.
So what I would say here, and I'll kind of answer both of these points. So one of the advantages of terlipressin is that you don't necessarily need to be in an ICU. And I think one of the big game changers that we're really waiting for in North America is the ability to trial vasopressin in a non-monitored setting. So certainly, if at first try, I would probably initiate terlipressin if it's available, because you can titrate it from 0.5 to 2 milligrams every 6 hours. And I know that there's the one study from Italy that used an infusion, but generally you need to do that in an ICU setting. And kind of what our practice would be is that if you're now a terlipressin failure, if you're getting progressive AKI despite terlipressin, that's generally when you get the ICU consult to go, and now you need the addition of norepinephrine. So if you have both of those at your disposal, that would really be the recommendation. And my hope would be that with terlipressin that we wouldn't be using midodrine to a significant degree. With regards to the second question that is asked about the use of 5% albumin, so an albumin challenge is appropriate, and if you feel that somebody is volume deplete, then 5% albumin rather than 25% is a reasonable option. What I would just mention as well, and this is just personal best practice, not evidence-based, is that generally we tend to under-resuscitate ACLF patients with crystalloid because of concerns of ascites, but there are people that will actually require liters of crystalloid like plasmolite or Ringer's lactate. So I would not be hesitant to use crystalloid as part of your resuscitation.
Dr. can I intervene here? What would be a role of albumin in patients with ACLF in their ICUs? How frequently do you use albumin and how will you use it?
So I think it should, well, there are, certainly as somebody who is hypoalbuminemic, it is reasonable to use, we do have patients where certainly if they have AKI and sepsis, we would be using 25% or 5% albumin. But what I would say is that generally after kind of the first, 24 or 48 hours, certainly if their albumin is close to the normal range, it really shouldn't be your resuscitated fluid of choice. That's really just my point, that I think you can get osmotic complications in the kidney if you over-transfuse albumin, and we've seen that in some cases.
Yeah, Dr. Sona, you want to go for the second question? Dr. Dean, the second question is, many times if the acute person is ACLF, it's treated but still the SIRS and modes persist. And what is your experience with cytokine filters? Do you use cytokine filters, and if so, in what situation do you use cytokine filters in ACLF?
So that's a very good question, and and there's a lot of interest in cytokine filters. There was the Euphrates trial. I will be honest with you, this isn't something that we use widely at this point. I know that some of the arguments is that you can remove the lipopolysaccharides associated with bacterial sepsis with some of these filters. While there's a lot of interest, this is something that still is only being used in certainly in North America in a trial setting, and I think further information is needed. Is really all I can say.
Dr. Dean, what about plasma exchange in ACLF? Do you use as a bridge to transplant plasma exchange?
So that's a good question. So we know that there is good data for plasma exchange in acute liver failure, and probably part of the reason for this is that these patients have a high amount of acute necrosis, and there's a lot of inflammation. The challenge that we deal with in ACLF is that a lot of these patients are it's partly a burnt out liver, and secondly there's a component of inflammation. And I know that there is the ongoing Apache trial, which Javier Fernandez in Spain is leading, where they are looking at plasma exchange in ACLF. My personal opinion is if you look at the Mars trials in ACLF, they were negative. And I suspect that this may be, we might get a similar finding with plasma exchange, just because the amount of the potential for hepatic recovery in ACLF is obviously less than in ALF. But that being said, I think that question is probably going to get answered by the Apache trial. So we're not currently using plasma exchange in ACLF.
Yes, thank you, Dr. Dean. And there are two questions from Dr. Nipun Verma. The first is, what's your practice of starting antibiotics and antifungals in patient ACLF who are culture negative? And do you routinely do a prophylactic therapy with antifungals and antibiotics?
So that's a very good, that's a good question. And what I would mention is, so in my own personal practice, we know that certainly somebody on the transplant list, the challenge that we run into, like everybody else, is the use of broad spectrum antimicrobial therapies associated with fungal sepsis in an ACLF patient. So certainly somebody on the transplant list that has ongoing fever, despite broad spectrum antimicrobial therapy, will consider early or empiric antifungals if they're on vasopressors. What I would say though is that for generally somebody that is not on organ support, I would probably do it based on cultures, and we do use tests such as the galactomannan test and beta-D-glucan. The challenge you run into with procalcitonin, and we have done procalcitonins in non-ACLF patients, is we know that there is probably the confounder of somebody that is inflammatory. You can get an elevated procalcitonin level. So we've seen that in some patients. So certainly in acute liver failure, even in the absence, not in acute on chronic, but in the absence of sepsis, you can have a high procalcitonin level as well. So that is something that tends to be quite challenging.
And Dr. Niburas asked about your experience with D-galactomannan and other serum markers for fungal infections.
So the one thing I will say with the galactomannan test, which I've used more, is for aspergillus, the only challenge you run into is there is a confounder with plasmolite and with the use of piptazo. So that's the one thing that you can sometimes get a false positive. So we will use the galactomannan in combination with other tests. So you'll look at your other culture results as well. But we would, in some cases, will empirically treat.
This question from Dr. S.K. Mathur, and he wants to know what would be your contraindications for a transplant in ACLF. When did you say a patient in your ICU is not a candidate for transplant?
Yeah, and that's a very good question. I didn't kind of have a chance to go through all the data. So this goes back to what I was mentioning, is that if you look at a lot of the new studies that have been coming out of UNOS, and even this happened in a study that we published in Canada back in 2013, is that most post-transplant outcomes in ACLF show a 1-year survival of 80%, which sounds really good. But the reality is, more than probably close to 50% of these ACLF patients that are listed for transplant that end up in the ICU don't make it to transplant. So we call this concept the counterfactual, that if we look at the patients that probably are either becoming unsupportable or people that we're making the decision as a medical and surgical team to decline, their outcomes to transplant would actually be very terrible. So my point is that when you see like Vanessa and Darren was published, but I was involved in these studies, the numbers look artificially good, and we all admit that because that's what we call the necessary selection bias. That if we weren't doing our job, if we weren't doing it well, then we would probably see much worse outcomes when you look at the UNOS guidelines. And there's always that trade-off that if you're very selective about the people you transplant, then if you look at your center, your wait list mortality will go up. And I know that it's even more relevant in centers in your part of the world because you rely quite a lot on live donor transplant, and that's a big issue with ACLF. So at this point, the simple things that we'll use is certainly if you're certainly over 65, but even over 60, if you have ACLF with 3 or more organ failures, most likely we wouldn't go ahead. And that was just, there is data that shows that increased age in ACLF is associated with worse post-transplant outcome. And I think also you need to think about this, certainly if you're using a partial graft. With regards to the specific organ failures, probably respiratory failure is worse than the other ones from a transplant point of view. So I think that's the second question with regards to the runway you need. So to get somebody through a transplant, if they're on max pressors and on 70% oxygen, you don't have the runway to get them through a transplant. So either you give them 48 hours to improve, and if they don't, then probably at that point you might have to palliate.
Yeah, Dr. Sonal.
Oh no, just the last 2 questions very quickly. I'm just going to start with Dr. Mathur's question that are ACLF patients prioritized on a deceased donor waiting list?
So that's a good question, and Vinay and Darren actually recently published an article that mentioned that so the short answer is no. That North America still is based on the MELD and the MELD sodium, and there were a few changes in the allocation rules in the U.S. And I know that a lot of this data is U.S. centric. But one of the interesting things that Vinay found in this UNO study was that if you compared patients that had ACLF grade 3 or higher, their waitlist mortality was actually higher than patients that were listed status 1 or with acute liver failure on the UNOS list. So probably there are things in ACLF that aren't completely reflected in the MELD score or the MELD sodium score. That is what our current allocation policies are based on.
Okay. Thanks. There's a question for the role of GCSF in ACLF. Is that part of your practice right now? Or?
So that's a good question. There's been several conflicting studies on the use of GCSF, and that for that reason, it's not something that's standard of care or something that we use routinely.
Sure. And finally, I think this probably will be the last question. Do you practice any futility of care rules in your ICU? I mean, I must say that we've had a couple of excellent talks earlier in the Feld sessions on the role of palliative care in liver disease, and one of Professor Karvellas' colleagues, Dr. Punita Tandon, has done some good work in this as well. Do you have any guidelines that are followed currently in Edmonton about futility of care?
So, and that's a really good question, Sonal. And as one thing I can give you, or kind of a twofold answer. Part of where this interest in palliative care here came from was that we did an audit back in 2014, and we looked specifically just at patients with alcoholic cirrhosis that were declined for transplant, and we found that the referral rates for palliative care were terrible. It was only 11%. So that identified a fairly clear care gap. And after kind of some of the data that I've showed you, it highlights that certainly once you get 4 or more organ failures, your waitlist mortality goes up quite significantly. So generally for that reason, it is important to actually involve palliative care, even if you're still on the transplant list. And I think they can be hand in hand. So like I said, because it's very hard to derive rules because because of the nuances of the selection bias that we delist the sickest patients, it's hard to necessarily come up with a rule when to kind of incorporate palliative care. But what I would say is that we certainly realize that we need to involve palliative care earlier. It's actually pretty straightforward in the non-transplant candidate, but even somebody on the transplant list, certainly if they have 3 or more organ failures in the ICU setting, we will get our palliative care doctors involved. One of the biggest challenges that we run into is just the fact that we don't have a large number of palliative care physicians, and obviously they're dealing with a lot of people with traditional malignancies. And non-malignant palliative care is kind of a growing area and a real big challenge for these people at the moment.
Yeah. Well, thank you for nicely sort of summarizing that last bit. because that's perhaps an area of unmet need in most ICUs, including our own. Once again, thanks very much for taking the time. It's early in the morning on a cold Canadian winter, I'm pretty sure. Thank you for getting up and being part of Field yet again another year. And hopefully we will get you across in person once the pandemic is behind us. Thanks again.
Thank you so much. Thank you so much, Charles and Sonal. It's a real pleasure.
Thank you.
Thank you, sir. Thank you.